Okay. So what are the indications for adenoidectomy? Number one, in our center, it is sleep apnea. So if the patient complains of snoring and sleep apnea. Number two is recurring attacks of secretory media, not resolving at all with antibiotics and all. And you see that the adenoid is the culprit. And number three is recurrent attacks of sinusitis in a child. So every now and then they have sinusitis, and that is producing problems. Then we will go in and remove the adenoids. So this is what is our indication for adenoidectomy. Of course, tonsillectomy, if the patient has more than 4 episodes per year for 3 consecutive years, sleep apnea is another indication in children. So we are going to do this case and you will see how it's being done. I'm going to wash up and come back to you. And I have my own technique for this. I'm going to show you how we do it. Okay, so the first step, Ma, can you, the very young child, around 5 years old, I'm going to pack the nose. Don't use adrenaline, just Otrivin nasal drops. Give. Secret kudra. I'm going to pack the nose now. See how I pack? It's the same endoscope, 4 millimeter endoscope. Hey, 3 millimeters irka. 3 mm scope irka. Kudu. So I'll change to 3 mm because it's a very, very small nose. See the choanal banking effect. It's called the choanal banking effect. So you have a lot of secretions which are pooled in the choana. So that's called the choanal. What solution? Keep giving me packs, please. So nicely pack and wait. That's very, very important. Many people, they're restless. They don't want to wait. Here in a child like this, you have to wait. And even though it's around 4.5, 5 years, you see the development itself is a very poor development of the nose. Usually you have a slightly bigger nose in this kind of babies, which are 4.5, 5 years. But this baby is very, very small nose. Okay. I'm trying to pack as much. How many packs? Just have a count. Huh? Okay, I'm going to wait for just a minute and then get the nasal infant feeding tube catheters. Okay, right. So this is the infant feeding tube. Have you seen this? Okay, this is the infant feeding tube. Have it. Now, what I will do is, adenoid blade, the mouth gag kuduthuruma. 2.
Yes, it's for the palate and for getting out.
What? The side is very narrow, man. 1, 2. Hey, this is not working. Konja adrenaline poduma. Suction. Small suction, all ear suction. Ear suction irukka. Hold. Hey, irukadra. Okay. Leave. See the adenoid. See. What's happened now? You see? It's completely blocked the nasal cavity. Can you see that? So the first step again is elevation of the lateralization of the inferior turbinate. How do you think this child would have taken breathe? The air through the nose? It's almost impossible. See here. Can you see that? Oh my God! See that? This is pathetic. So it's an absolute indication for surgery. You understand? So this will lead to sinusitis very often, sleep apnea. Yeah. Give me now the pack. Same way, I'm going to do it on this side. We got a little septal deviation as well. Wait. Septal deviation. So again, you have to be patient. You have to pack. This is a little challenging case, not like easy. Ma, ear idu kuduma. Sir, blood is a little dark. It's okay. Blood is a little dark. Is it okay? They just have the pack count. So in case you have such a crowded nose, then we may not be able to operate through the nose. I have to do it through the nasopharynx, yeah, from the mouth, because it's very crowded. If it's slightly better, then I would have done it through the nose. This is absolutely impossible to do it through the nose. And one side, there's a deviation also. Okay, give me now the mouth gag. Boyle Davis mouth gag. Ma, hold the tube. So, ma, want to hold it, is it? So use a small size tube, a small size gag. And then try to put it. Okay, right. Okay, right. Hold. Now you see here what I've done now. You can see the huge tonsil as well. Can you see that clearly? And you can see now what I do, I keep it like that. And now I have to do it through the mouth, but let me see. If I can do through the nose, it's very easy. Because if you do it through the mouth, both your endoscope 70-degree and the uh, debrider are all through the, oh, you see, it's completely blocked, my dear friend. It's completely blocked. Oh my God. This is like crazy stuff. Oh my God, it's my ear suction kurma. என்னண்ணா பிரச்சனை? Suction. Give the catheter. Blexley. When I say push, you push, okay? Push. Push. Bloody block completely. Okay, right. Now, see the catheter here. Now, what you do is you have to tie this, okay? So that's the first step. Loosely, not tight, okay? Very loose. Okay. Now, one more catheter. So this side is a little tricky. The reason is because the septal deviation as well. Yeah, somehow I got it going there. Okay, all right, now let me see. Give. Now always put two catheters because you need to be symmetrically pulling the soft palate. You understand? Don't put just one, it's not good. Okay, right. Now, little loose, not tight. Okay, right. Okay, right. Now here we are. I'm planning to do it like this. You see here. Now you have to lift this, my dear friend. Okay, give me a suction. Now you have to irrigate. The main thing is you have to irrigate through the other side, other nostril. Hey, what is this? What is this? Hold it when I go inside. Suction. Oh, see that? Can you see here now? Now you see that's the completely blocked nasopharynx. Give me the debrider. So what I will do now is I will introduce my RAD 60 debrider blade like this. It's a very narrow nose. And I want to see that debrider coming out. Where is this coming out? Wait. Hey, pull. Oh, now I got it. Oh, can you see that debrider? Can you see that? Now keep irrigating. So this is easy because it's a different port. So you're not having the 70 degrees a little, difficult. So first is you just try to debulk the whole mass. It's a very big adenoid. Irrigate. You're not irrigating, my dear friend. Irrigate on the scope now. Good. For this time. See, the tonsil is seen from here. Keep irrigating. Irrigate. பா இன்னொருத்தர் யாரா வாங்க வாஷ் பண்ணுங்க. Irrigate on the scope. So the main thing is you have to keep irrigating, 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 irrigating. If you don't irrigate, you will start having a lot of bleeding. Irrigate. This is the tubal tonsil. This is over the eustachian tube. Don't damage the eustachian tube, but you have to take the tubal tonsil out. Okay, that's the salpingopharyngeus fold. Oh, good, Radha. Now the movement is always like this, side to side. See here. This is the movement, because you don't want to hit the perimysium of the irrigate muscle. You understand? So that's the first part of the surgery. I just want to go this side and have a look at how I have operated. Okay, this side also is good. Okay, can you see now, all of you? So this is stage 1 of the surgery. I'm already started seeing the muscle. Can you see the perimysium? Yes or no? Irrigate. Can you see the muscle here? Here. See that? So when you do like that, you can see the muscle. Very beautifully seen. Irrigate. The idea is to see the muscle. I mean the perimysium over the muscle. Then you are in the right plane. So that's the fossa of Rosenmuller. You see here. I'm going towards the tubal tonsil. You see that clearly? I'm going between the beautiful. Now I'm very happy. Scope. Keep irrigating, my dear friend. Oh, good. Leave it. Okay, so I have done my first step of debulking the adenoid. Now, what I'm going to do is to pack. Give me a pack. Is it easy? This is easier than your technique? More expensive? Oh, no, but the debrider, you have to see the perimysium.
The reason why you don't use the debrider.
Oh, you don't use the debrider, then you can't see the perimysium. Every case, I always say you have to see the perimysium of the longus capitis. That muscle is called longus capitis. You understand? Now you see what I do is there's no good mouth opening also. Wait. Okay, suction. So this is the stage 1. The stage 1 is you completely debulk everything. See the adenoid, it's almost kissing adenoids. See that? It's very big adenoid. You see that? So what I've done is just pack the nasopharynx, sorry, and just wait, okay? And now keep irrigation. Keep irrigating the nose. Give. The idea of irrigation, why do you irrigate? No. The irrigation is, it acts by extrinsic pathway of hemostasis and it causes hemostasis. That's why you irrigate with a little warm saline. Keep irrigating. It helps in hemostasis. Okay. Yeah. On the side, என்ன போட போறீங்க? Isolated sphenoid. போட்டுருங்க. அங்க start. Now what I'm going to do is I'm going to take off that 2 packs and get ready with the coagulation now. Now what I will do is I'm going to see and inspect what I have to. Wow. See that? Beautiful, beautiful, beautiful. Now what I will do is I'm not going to coagulate. Wait. Give irrigation. I want to see if I've done it completely. That's very important. You see, it's not a matter of just doing adenoid. Doing adenoid completely is very important. Now give me the debrider again. Now I want to see the perimysium. Hold this like this. Little. I want to see the perimysium because there will be a recurrence of adenoid if you leave it behind. Not too much, my dear friend. Give debrider. Now I'm going to use it again now. I want to see where all I have left behind. See, that's the muzzle. You can see the muzzle. So a little bit here, a little bit here. This is the tubal fossa of Rosenmuller. Be very careful. Don't disturb the that's the eustachian tube orifice. Okay. You should remove it completely. That's the muzzle. Okay, that's beautiful. Midline raphe. Wonderful. So I'm very happy with the left side. That's the basio-occiput basisphenoid. This is the choana. Okay, that's perfect on the left side. I go now to the side and see suction. Whether I have removed it completely. The main idea of adenoidectomy is to remove it completely. Hey, suction, Udupa. Why is it not sucking then? Huh? Why? See, many people do adenoidectomy and they do incomplete adenoidectomy. So we have seen recurrence of adenoidectomy, adenoids. I've seen recurrence of adenoids because they do incomplete work. See how I'm manipulating my 4mm endoscope. Okay, that's beautiful. Give me the debrider. I have a little adenoid above. I'm going to take that out. See here. This is again a little adenoid. You can see that very clearly, the tissue there. Along the fossa of Rosenmuller. Can you see that clearly? Hey! Deepak, okay, that's perfect. Complete removal now. I'm very happy about it now. This is 100% removal of the adenoid. Now what I'm going to do is to pack Don't coblate. Many people, what they do is they start coblating. This is what I don't do. I don't do, because by coblating, what you're going to do is to destroy the perimysium. You're going to destroy the normal anatomy. And what is happening is it's going to cause a lot of pain for the child. The main problem is the perimysium is very pain sensitive, and don't put some cobblator or diathermy or anything there. It's going to be very, very painful for this kid. So the best would be a cold steel. Okay. Now what I will do is I'll just keep it like this. See that? Suction. Give me big suction now. Give me big suction. Okay, that's perfect now. I'm very happy. Okay. Now what I will do is I'm going to remove this, and I'm going to take this out. I'm going to remove this, and I'm going to take this out. I'm going to remove this boiled Davis mouth gag and change the position of the child. Take my glass out. Okay, so it took hardly around 10 minutes, but we did a complete job. Not that we left behind a little bit in the fossa of Rosenmuller. These are areas you have to take care. Keep the head down. So you do a different technique, right? Yeah. Yeah, I know. It's there here also. See, like this. But this is, yes, you have both. Yes, we have both. But it's not a good technique. It's an old technique. Ready? Shall I start? Now I'm going to go for the tonsil, and I do the tonsil with a coblation. Okay? You also do that same? Okay. I'm going to show you a different technique. It will not be the same. Okay, are we ready? Are we ready? My dear friend? Are we ready? Move. Ennamma. Hey, கண்ணா பிரான் பண்ற. Urri. Ready? On, lights on. Light on. Okay, are we ready? Hey, why you didn't keep sandbag on the shoulder? No, you have not kept. This is the position of the baby. Hey, kanna plan பண்ணாதீங்க. Okay, give the boiled Davis mouth gag. அண்ணா எக்ஸ்டென்ஷன் இப்படி வரணும்ண்ணா. Fine. ரெடி? ஏய் பிடிச்சிக்கோங்க. நவுந்துட்டே வருது தலை, அதான் தெரியல என்னன்னு. சரியா இல்லையா? Hold the head, man, like this. Now the main thing is, see here. Can you see now? The tonsil very clearly. You have to hold it like this. Deepak. Now, come on. Give me the coblation. Hey, not you, this one. Coblation. See, you hold with a valsalum. I like this instrument called the valsalum. And then you pull it out. See, you have to see the junction of the tonsil with the see, that's the plica, and this is where you have to make the incision. So you keep both your foot on the blue and the yellow. First is the yellow. Tanni. See that? Can you see that? And then what you do, you have to identify the plane. That's the plane. See, you will see the bluish. Can you see the fibers there? So in the regular coagulation tonsillectomy, what is done is they start coagulating till the end. But my technique, it's different because I don't coagulate. I use the coagulator like a elevator. So same like the mollisons. See here. வேணாம் வேணாம் நீ பேசாம இருக்கணும். ஏ ரங்கா இல்ல. See the fibers. Can you see the fibers? You have to use it as an elevator, my dear friend. That is Janakiram's technique. See, I always like that color, the pinkish color. I don't like the whole fossa becoming white. This is something I don't like because this gives the best healing. You understand? That's the posterior pillar. Save the posterior pillar as much as possible. You understand? See how beautiful it is now. See how beautiful it is? You do this technique? No. I don't like if a person uses too much of coagulation in the fossa, you will have pain. So the next one, and you should see that, see, we don't put the jack. We ask the sister to hold it, if you see the difference. And more importantly, see the exposure we get. Hold. Right. Ready. Okay, right? Hold it at its head, the tonsil at its head, and pull. Once you pull, you will see the junction of the tonsil with the mucosa. Use the yellow gently, okay, to identify the plane. See that? Now that's a plane. Once you get the plane, it's very simple. You just have to start dissection. See that? See that? See that? So you start dissecting once you get the plane. Preserve as much of the anterior pillar and the posterior pillar as possible. That is actually physiological, very physiological. This is what is called, I always call this the lateral medial dissection. This is the lateral medial dissection. That is, you pull the tonsil medially and dissect the fibers laterally. This is called the lateral. See, that's lateral, this is medial. So this is not the classical anterior posterior dissection. Anterior posterior go like this. But here we do from, that's the posterior pillar. Posterior pillar and anterior pillar have to be cut. Always remember that. You cannot elevate. You have to cut the attachment from the posterior pillar, sharp cut. Never try to elevate from the anterior and the posterior pillar. You have to cut. See, the problem in the coblation is that if you are a novice, what happens is you lose the plane and you might land up doing an intracapsular procedure. So this is the best way to do the extra see the vessel entering into the lower pole. I'm going to show you in very high magnification how the vessel enters into the, see the vessel here. Can you see how it enters? See here. Can you see that? Now you have to go close to the tonsil. See that? There is a vein here. Can you see the vein here below it? That's a paratonsillar vein. Try not to hurt that vein. You don't want to hurt that vein. It will cause bleeding. Can you see that very clearly, my dear friends, here? See how that vein went off from the field. See, oh, wow, what a beauty, what a beauty. I love it, man. See, the idea is to make that fossa look like an apple, not like a anemic fossa. Elevator. வந்துட்டியா? முடிஞ்சு. எப்போ வந்த? வீட்டுக்கு போயிட்டு வா. Right, over. And side முடிஞ்சு. So I'm just going to see the adenoid now. It's a beautiful way to do adenotonsillectomy. Many people still are doing bad adenotonsil. Even the basic procedure like hold. See how much of the anterior pillar I have preserved. You see that? See how beautiful it looks. So beautiful. Absolutely no bleeding. Fossa looking beautiful. No breach of any of the caps, the muzzle layer. You can see how nice the muzzle layer looks. Finished. That's it. Okay, this is my son, Francisca. Introduce yourself to my son, Sathya. Yeah, finished. Now I go back to the adenoids. Okay. Position change. The only problem in this is The advantages, disadvantages. Disadvantage is you change the position twice. The advantage is you don't unnecessarily coagulate or cauterize. Which is better? You don't want pain. You don't want, anything related to, unnecessary coagulation or cauterization. So I don't mind changing the position twice. You understand the concept? Yeah. Yeah. Give. No. Anyway, I have to put the boiled Davis. Chinnada ide. Chinnadu. Always when you use the adenoid, use a small boiled Davis mouth gap. This is the small one. Okay. All right. Now give me that nasogastric tube, the infant feeding tube. Come on. Now, first let me take off that pack. Suction, please. I'm just going to see the adenoids. See how beautiful the epiglottis, everything is seen very nicely. Now I'm just going to take off the packs which I placed there. You know what the packs are placed for? Number one is by pressure, it acts. Number two, again, by extrinsic pathway of hemostasis. See that? That is the first pack coming out. And that's the second pack coming out. Okay? Right. Now, let me have a look at what's happening inside, whether there's bleeding at all. Suction, there's no bleeding at all. Absolutely no. Of course, I want to make sure that there's no bleeding. Give me the nasogastric tube a little bit. So even that amount of bleeding I don't want. So what I will do is, I'll show you what I will do. Has it come down? No. Suction. So always you have to put a nasogastric tube because you don't want to cauterize the uvula. The uvula should not become edematous after the surgery. You understand? I don't want the uvula to become edematous. So we always put the tube. Okay, here we are. Now what I'm going to do is you have to keep on irrigating, my dear friend, from the other side. The main thing is I don't want a clot. So what I do is I keep irrigating. Wait. From the other side. Wait. Give me coagulation now. So there's no bleeding at all, but anyway, I will irrigate. Coagulation. Irrigate, my dear friend. Keep irrigating. Irrigate, my dear. Irrigate, my dear friend. Fast up, bursts of irrigation. It has to move the clot. Okay. In the side, irrigate. Yeah. So this one is a complete excision of the adenoid. Can you see that clearly? And no coagulation required for this. Absolutely nothing. That's the way. Who is doing this? Radha is far better because she's eating non-veg. Deepak is very weak because he is not eating non-veg, I think. Okay, that's it. Finished. Okay, so I'm not going to coagulate at all. So that's the advantage, I tell you, that you don't want to unnecessarily coagulate anything and make it like a pitch dry feel. That's it. Finished. Thank you. So I hope you learned some new technique of both adenoidectomy and tonsillectomy. Of course, the next case is far more interesting. Give me a glass. Coagulation is 7-3, my dear Amit. I hope you enjoyed this surgery. Dr. Gupta is there. Dr. Gupta, you can unmute yourself and you can talk.
Yes, sir.
Did you see the surgery?
Yes, sir. Very nice place, sir.
Yeah. So, you have any comments?
You have used this collator as a dissector.
Yes.
It was a very
Correct.
nice idea, sir.
Yes. And another thing is the adenoid, don't immediately jump and do some cauterization and coblation. Don't do that.
Yes.
If you do that, you're unnecessarily causing, giving more energy and also producing more pain post-op.
Yes, sir. Sir. Yes.
Okay. And when you
Yes, sir.
irrigate, sometimes what we do is we also put some, little with a gauze. You just
Yes, sir.
sponge it with a little 2% xylocaine. Don't make it into the larynx. If you put that,
Yes.
no, then they will aspirate. So
Yes.
just little bit there you can put. That's all.
Yes, yes.
Okay, so I
Yes, sir.
think you had a good idea. Shyam sir is
Yes.
there. Shyam sir, do you want to say something? Comments?
In which setting you are doing adenoidectomy?
7-3. Oh, in
We
setting?
generally,
No. We
Yeah.
do it with debrider.
because coblation adenoidectomy usually it is 8-4 or 9-5.
I don't like coblation adenoidectomy. I don't like, because you see, the thing is, yeah, number one, it takes time. Number two is
Yeah.
that if it's so big like this, you have to bend the coblation band. You saw
Yes,
it was going till the quina. You
Yeah,
cannot
yeah,
do
yeah.
that with a straight coblation band. So if you
Yes.
bend, it will get obstructed. It'll the channel will get clogged very often.
Yes.
So I don't like if it's going right till the quina, coming inside the nose, then it is coblation adenoidectomy is not good.
Yes, you are right. Many a times the coblation adenoidectomy, people say they have done, but some remnants are always left behind.
Correct. You have to see the perimysium. See,
Yes.
if you make everything white, how will you differentiate perimysium, adenoid? How will you differentiate? You cannot. So
Difficult.
you should do only cold steel dissection, see the perimysium, and after that, if there is bleeding, you coblate. That is the right
Yes.
technique.
Yeah, even I follow that.
Yeah, excellent, sir. Excellent. I think Dr. Amit Patidar, are you there? Amit is my close friend. I think he's left. Dr. Sanjeev Kumar is there. Sanjeev ji, do you want to comment, Dr. Sanjeev? Sanjeev is my close friend. Okay, I think he's not able to hear. Okay, so I will come back with one of the most interesting cases of this month. You will be seeing a huge tumor operated 4-5 times before going inside the brain. And you will see that this is being done right now. Another 15 minutes give us. We'll be back with another YouTube, the web Zoom link, another Zoom link. Okay, guys, thank you very much. Bye-bye. Have a nice day if you are checking out, or if you want to come back.